Good afternoon, everybody. Thank you for joining us. Thank you for coming. Thank you for watching today's program. The Ananda Sharma Visiting Professorship and the Simon Dack Lectureship that we heard at 12 noon. This program occurs monthly where we get internationally renowned figures in medicine, particularly in cardiology, to sit as part of a moderated panel discussion. Always generates very, very lively discussion. Today we really have a special treat, one of the most renowned collections of people experts in the field. Each and every one of them could give a full hour's lecture that you would be fascinated by, but particularly today to have them on the panel I think is truly unique, and you'll hear more about it in a moment. Our last speaker of this current academic year is going to be in June, Chris O'Connor from Duke, and that's going to be on June 16th. To tell you about next year's speakers, I'll give you more detail. The first few months, September, Dr. Deck from Mass General. In October, Bernie Gersh from Mayo Clinic. In November is Lawrence Sperling from Emory. We have, again, a star-studded lineup for next year. This program, people can turn on and watch on the web at heart-talks.com. And I think that today particularly is going to be one that you're going to enjoy over and over. This particular group of people on today's panel, besides our visiting professor, Dr. Kohler, you'll hear more about, Juan Batamon, Professor of Medicine, Director, Atherothrombosis Research Unit, Samir Bansalai is Assistant Professor of Medicine, Interventional Cardiovascular Research and Clinical Trials, Dr. Valentin Fuster, some of you may have heard of. He's going to be on the panel because he has asked Dr. Vorsheimer, Associate Professor of Medicine, to lead moderating the panel. Dr. Jean-Sebastian Hulot, who's Associate Professor of Medicine, Cardiology here at Sinai, and the Director of Pharmacogenomics and Personalized Therapeutics, John Halpern, one of the outstanding leaders in the field. Who's the Robert and Harriet Heilbrunn Professor of Medicine, Director of the Clinical Cardiology Fellowship Program, the Zena Michael Wiener Cardiovascular Institute, and Dr. Sharma, Director in Clinical Interventional Cardiology, President of the Mount Sinai Heart Network. The fellow who's going to give us a brief overview of the subject is Benjamin Hirsch, who's put together an excellent monograph. But before we do that, around 2 weeks ago, there was an extraordinarily complex patient who was admitted to the CCU. And following the very outstanding work he did, I got letters from several different people, particularly in nursing administration, nurses themselves, house officers, talking about the outstanding job he did, sublimating his ego, working as a team player to bring the case to its fruition, where the patient was diagnosed for a complex disease, but probably was able to do so in a much shorter time because everyone worked together. In recognition of that, today Vilma and Kathy, who are representing the nurses in the CCU on behalf of nursing, and really demonstrating the cooperation that our doctors every day, all of our fellows and doctors do, want to present Benjamin with a plaque of their appreciation.
So on behalf of the entire CCU, we present Dr. Benjamin Hirsch, his excellent job last Friday.
I'm not kissing you.
Good afternoon. Thank you, Dr. Goldman, for a very kind introduction, and welcome everybody to Controversies. So amongst other esteemed faculty today, we are fortunate to have Dr. Barry Collar with us, who as many of you know, has accomplished a tremendous amount towards our understanding of platelet aggregation and atherothrombosis. Today we will be addressing many of the commonly encountered questions in the treatment of acute coronary syndrome with dual antiplatelet agents. Many of the questions being asked are some of the same questions that were asked over a decade ago, such as the treatment duration necessary for dual antiplatelet therapy after PCI. However, we are again asked to revisit these questions now that we were presented with new data and new therapies, including the new thienopyridines, the development of new stents, the novel oral anticoagulants, and advances in genomics. Before I delve further into these issues, I would like to take a moment to offer perspective on where we are in the science and how our understanding of platelets in thrombosis has evolved. Our initial appreciation of aspirin was brought about with the understanding of the roles of the COX pathway, as well as the elaboration of thromboxane A2 in the setting of endothelial damage. Next was the discovery of the G2B3A receptor as a final step in platelet aggregation, for which Dr. Collar was one of the leading pioneers. Our current era of dual antiplatelet therapy is derived from our understanding of the ADP and P2Y12 receptors. We then move on to the clinical realm, where success in clinical trials, particularly out of the TIMI group, has refined our use of these agents. The CURE trial was one of the major studies that ushered in our current practice of dual antiplatelet therapy following PCI. Subsequently, many other trials suggested greater benefits with the newer thienopyridines in terms of less inter-individual variability, more rapid onset of action, and more robust platelet inhibition. The Triton-TIMI 38 study and the Plato trial demonstrated mortality benefits of both prasugrel and ticagrelor respectively, but at the risk of greater bleeding. Subgroup analysis in these studies further highlighted the importance of patient selection, such as the greater benefit that was seen in diabetics when considering these new agents. Other studies, such as the Prodigy trial, focused on duration of therapy and refuted the efficacy of greater than 6 months of dual antiplatelet therapy. Another very controversial question that has drawn much attention is what to do with patients on oral anticoagulation, most commonly for atrial fibrillation, who then undergo PCI. Clearly, the risk of bleeding when on dual antiplatelet therapy is added to the addition of an anticoagulant is very high. Furthermore, any incidence of bleeding raises the risk for stent thrombosis as well as stroke due to cessation of therapy. To this end, data from the West trial suggests that the use of clopidogrel and warfarin is as efficacious as triple therapy and with less bleeding. However, with the development of novel oral anticoagulants, which are clearly preferable to Coumadin in patients with atrial fibrillation, but have not been tested against the new thienopyridines, we are now again at a point where we are searching for guidance from clinical trials to help make decisions. Also, there are now very recent TIMI studies that have attempted to use these novel oral anticoagulants specifically for the purpose of reducing stent thrombosis, but in most cases the bleeding has been prohibitive. The Atlas ACS-2 study looked at a very low dose of rivaroxaban, about less than a fourth of the dose that was approved for atrial fibrillation, and they added it to a dual antiplatelet regimen and reported a reduction in stent thrombosis, as well as a reduction in major adverse cardiovascular events, but with higher rates of bleeding. Similarly, the Appraise-2 study, which looked at apixaban in essentially the same setting, was terminated prematurely due to an increase in major bleeding events. Likewise, with new procedures such as TAVR, we are using dual antiplatelet therapy for stroke prophylaxis without much data to support this approach. So altogether, we are now at a point where we are faced with many new options for treating patients for ACS and atrial fibrillation together, but without comparative studies on the high bleeding risk when using thienopyridines alongside the novel oral anticoagulants. While we debate the use of new agents, we look towards other technologies in the field, such as individualized genomics, and the possibility of targeting new platelet receptors, such as the GP6 receptor, that have shown more specificity in the antithrombotic and inflammatory pathway in comparison to the hemostatic pathway. Such inhibitors have the potential of equal efficacy with less bleeding, further broadening our therapeutic dilemma. Other platelet targets are questions for the future, but for now I think we have plenty of questions to occupy this session. Thanks very much.
Thank you, Benjamin, and congratulations by the recognition of the CCU. It's wonderful. Well, it's certainly an honor to introduce Dr. Barry Kohler again here to Mount Sinai, to our group. He's recognized by everybody, but I'd like to say a few words about Dr. Kohler's background. BA degree at magna cum laude from Columbia College in 1966. He obtained his MD degree actually from New York University School of Medicine. Actually, it was in 1970, 4 years later. He had his residency in internal medicine at Bellevue Hospital in New York and advanced training in hematology and clinical pathology at the National Institute of Health. Now, he actually joined the faculty of Stony Brook in 1976, where he became clinical director and head of the hematology division, clinical chief of the University Hospital Hematology Laboratory, and then he was director of the Stony Brook Foundation and associate director for biomedical research of the Biotechnology Center for Advanced Technology. Now, in 1982, he became professor of medicine and pathology at the Stony Brook, and he was awarded in 1993 the Distinguished Service Professor of Medicine and Pathology at the Stony Brook. He actually joined Mount Sinai in 1993, and he became the Mary Rosenberg Professor of Medicine and chairman of the Department of Medicine and chief of the medical service here in 1993 until 2011, where he moved across town and he became the David Rockefeller Professor of Medicine and head of the Laboratory of Blood and Vascular Biology at Rockefeller Medical Center. He was physician-in-chief at the Rockefeller University Hospital and vice president for medical affairs at the Rockefeller University. As a number of positions of responsibility that he has actually today. Now, to go to Barry Kohler's CV is quite simple and quite difficult. I think it's simple because he has been very consistent from the very beginning to what he wanted to do. And I still remember when I met him for the first time, certainly much earlier than joining Mount Sinai, he was working on a concept that at that time was not easy to grasp, which is a monoclonal antibody to inhibit platelet function. And I still remember on his first presentations of the topic, working in animal models, working in some patients in Israel, I still remember vividly how he moved step by step until he actually developed abscimab or Riopro. It was approved by the FDA in 1994 and has been used, I think, more than 40 million people. I don't know how many, but at least this is something you can say had an impact. But what was most interesting was to see him, how he moved step by step. And he has done this in many other areas of hematology. He has platelet function testing with the Acumetrics and others. And he certainly is a very persistent person and extremely accomplished. Actually, if we go back to his positions and his awards, he was is a member of the American Society of Clinical Investigation, the National Academy of Sciences, American Academy of Applied Sciences, Institute of Medicine, etc. And he had very important positions in the national and international scene. He was the president of the American Society of Hematology in 1997, 1998, founding president of the Society for Clinical Translational Science from 2008-2011, member of the Advisory Council of the National Heart, Lung and Blood Institute, 2008-2012, and so on. Now, he has numerous awards, as you can imagine, John Simon Guggenheim Memorial Foundation Fellow, International Investigator Recognition Award of International Society, National Heart, Lung and Blood Institute Merit Award, American Heart Association National Research Achievement Award. I feel very proud. I gave it to you at that time. With a Nobel laureate, I believe, Dr. Oliver Smith, isn't it? And then, and he has really so much accomplishments. And above all, he's a gentleman. I don't know how you define a gentleman, but that's what he is. Everybody who has worked with him in any aspect, you know, this is somebody that really deserves recognition as a person, as an individual, as a humanist. And it's a pleasure, Barry, to introduce you today again to all of us, and thanks for coming. It's a real luxury for all of us. And now I'm going to give this. So here you have the plaque. I hope you remember, which is from our faculty to Barry Kohler, outstanding teaching, wisdom, and expertise as an Andy Sharma visiting professor in the Simon Dag Memorial Lecture. Actually, he did something I have not seen before. He donated the huge honorarium that he received to the Fellows Program. Thank you. Thank you very much. You can sit there in the middle, and I'm going now to call all the people who are going to be on the panel. Dr. Borchheimer, he's going to very kindly decided to be the moderator. Juan Badimore, Samir, Hulot, Sebastian, Jonathan, and Samir Sharma.
There are. There's absolutely enough. I put it on myself. Okay. So thank you, Dr. Fuster, for the opportunity, or the challenge, I would say, to try to fill in. Worse than having to try to fill in for you is to have you sitting next to me while I'm trying to do it. Or more frightening, I should say. But let me also add my personal welcome back to Dr. Kohler. Don't worry, you don't need to look at the slide. Not yet, anyway.
You may be familiar with the place.
Dr. Fuster already alluded to the fact that Dr. Kohler was here. Although Dr. Gorlin actually hired me when I started here, it was actually Dr. Kohler who was really the first chief of medicine that I came to know. And I think many of us look back on those 7 years, like in the Bible, the 7 good years, as really, Camelot, the heyday of, the interaction between the Department of Medicine and the Department of Cardiology, and infused by really Dr. Kohler's spirit, by the inquisitiveness and the scientific inquiry that inspired us on rounds and in everything that was part of the mission of the Department of Medicine in those days. But as Dr. Fuster has just mentioned, especially by the enthusiasm and the graciousness of his personality, which also sort of really set the tone for an entire decade of work at Mount Sinai. So thank you for coming back. The second thing is, as I started to sort of think about a beginning point for the conversation today, Dr. Fuster asked me to sort of run through some hot clinical questions in the management of atherothrombotic disease, particularly antithrombotic therapy. And I kind of started to think about how we would do this, and I started to sort of turn back and think about, where we could sort of begin the conversation from. And moving forward from there, it occurred to me how much of everything that we as clinical cardiologists do on a day-to-day basis, the ideas that we take for granted, the practice patterns that we routinely practice every day sort of almost reflectively, were really generated by the folks sitting here, by the gentleman sitting to my left. It's really amazing as you think back at how so much of what we think today was generated in the imaginations of these gentlemen, was proven or refuted or refined in clinical trials that they came to sort of design and to execute and to report, and transmitted to us by the eloquence of their words and the power of their personality. And it reminded me, as I often think about cardiology, because my first attending when I was an intern in the CCU was Les Kuhn. And as those of you who remember the late Les Kuhn recall, he was a maniac baseball fan. We bonded quickly. On the second day of rounds, I think in the CCU, he came over to me, put his hand on my shoulder and said, "My boy." I was flattered, but I later came to realize he called everybody my boy. But he said to me, "What do you think you might be interested in?" I said, "It's like September of my internship, but I really think cardiology is kind of cool." And he says, "I have to tell you, unless you can tell me now 10 players who hit 500 home runs in their career, you have no chance at Mount Sinai." I'm sure Dr. Fuster agreed with that. That was actually a harder list because it was before, Sosa, McGuire, A-Rod, all the people who used drugs. I don't think I got 10. I think I got 7, but he was impressed that I remembered me a lot, so he let me pass, I guess. But it reminded me really that, the 1927 Yankees are widely perceived as having the greatest lineup ever in the history of baseball. All 6 of their first starting lineup positions went on to the Hall of Fame. That lineup was nicknamed Murderer's Row because opposing pitchers really had no chance. And I think what you see on display here, as Dr. Goldman really alluded to, is a lineup that's really unrivaled. There's no other place that could field this kind of bench in the modern world. And certainly to have been a trainee here and to have been a practicing physician here over the last 20 years, it's really been a privilege for me to learn from and to learn with these doctors. So thank you. Okay, we're going to do something a little bit different today. We're going to present some cases, and we're going to ask for your interaction. I think most of you guys have received the clicker cards, yes? Okay, so if you haven't yet, just take a minute, press the go button, which is the bottom on the lower left. Type in the number 41 and then hit go again, and then you should see a green light on the upper left right after the www on the card. So you guys up front want to vote, or you just want to? Okay, somebody in the back, if they could just grab a handful for these guys. Okay, so we'll start with the first question. So, Dr. Kohler, we obviously in cardiology have been thinking a lot about antithrombotic therapy for the better part of 2 decades. When I was a trainee, when I was a fellow, we used to think about red clots and white clots and how that sort of inspired different approaches to therapy. If you could just sort of summarize how we should be thinking now about the contemporary approach, particularly to antiplatelet therapy.
Well, first, let me say how happy I am to be back here and to be among my friends in the cardiology division, and also in particular comment on how one of the very first things I did and one of the very best things I did when I became chair here was to make a trip up to Boston to meet Valentin to discuss the opportunities at Mount Sinai, and that was a memorable dinner followed by a wonderful relationship that has extended ever since and has benefited me enormously and benefited Mount Sinai enormously, as well as the world of cardiology more broadly. So I want to make sure that I emphasize that, and also say that I had the opportunity to round with David on the cardiology in the CCU when I was chair, and those were uniquely instructive rounds for me, and I learned a lot and appreciated just what a wonderful educator he is, and also what a wonderful clinician he is. So you're very fortunate here to have so many terrific role models and to have such true expertise in arguably the most important disease that we face, not only in the United States, but increasingly throughout the world. So we better get this right. So I commented to the fellows after my talk earlier that it may pay to just take a step back and think about things from an evolutionary standpoint, because we use these terms anticoagulant and antiplatelet and we're sort of used to them. But we should reflect on the fact that we want to subvert a mechanism that was honed through literally hundreds of millions of years of evolution. To do that casually is not something you necessarily want to tinker with, because evolution is a pretty impressive process. That's not to say that you shouldn't intervene when you must, but you in fact should do it with a lot of caution when you choose to do it. And so I think that context is really important for understanding that we have to be really judicious when we do intervene to essentially subvert a mechanism that has been established. And so it's not surprising that it takes a lot of care to get the optimal balance. And I think that it's naive to think that our existing models are sufficient for us to make definitive predictions. And so painful as it is to say, we have to live within empiricism. It's also clear that we really don't have a lot of information about areas that are very, very important for even framing the question. So, for example, patients with hemophilia not infrequently have CNS hemorrhage. Patients who have Glanzmann thrombasthenia, who lack the ability of their platelets to aggregate, while they have a lot of mucocutaneous hemorrhage, very rarely have spontaneous CNS hemorrhage. So that already begins to tell you that even though we have the hemostatic mechanism, there are subtleties that we don't have a good handle on. And as we made rounds in the CCU, we made the point that if I were the head of the FDA, I would insist that everybody only do the toxicology studies on old monkeys, and chimed in by the House staff with multiple comorbidities, because we know that all of those things contribute to hemostatic risk. And I think one of the themes that I tried to develop earlier today was, while we talk about the drugs and their hemostatic risk, in fact, we should, in my view, be spending much more time trying to identify the risk factors in the individual patients, because I think it's individual patient risk factors that are as important or more important in assessing risk. And I think that we have not focused on that as much as we might. And I think that there's a lot of opportunity in there for making advances. And now that everyone has a handheld device that can be used to plug in a series of parameters to provide an assessment of relative risk, that these are things that we should be taking advantage of. So with all that said, I think that our models are that go back a long time are fundamentally not changed dramatically. I think that we view arterial disease as primarily initiated by platelet deposition, and actually Dr. Fuster did many of the pioneering studies with Dr. Battyman that really nailed that in fact the platelet was a very important culprit. But the platelet's role is primarily early on, and at the noon lecture I tried to emphasize that antiplatelet therapy is really quite effective if it's early. Later on, of course, the clot becomes consolidated, and then the role of antiplatelet agents is probably considerably less. I'd say whenever you damage a blood vessel, you will expose proteins that platelets will find irresistible in terms of platelet adhesion, and potentially, based upon how that first layer of platelets sit down, it may well attract additional platelets. So if you ever do anything that will disrupt the integrity of a blood vessel, or as happens sometimes spontaneously, you really have to be in there. I also mentioned that early on, when stents were first put in, there were massive attempts to use anticoagulants to prevent the stent thrombosis. But even though the patients were bleeding very badly, the stent thrombosis was ongoing. And that first study that showed the capacity of ticlopidine along with aspirin to be better than Coumadin in this setting was a major landmark in, again, understanding the important role of platelets in that setting. So I think that it's as you know, we have many different things that can activate platelets. If you think about a thrombus and you think about it dynamically, you can appreciate that you're not going to have all of them at the same time. that there's going to be a temporal pattern of the different agonists. And so where ADP is working, and now that we have Vorapaxar approved that interrupts the thrombin receptor on platelets, or one of the thrombin receptors on platelets PAR1, we know that there's an evolution, almost certainly an evolution, of the different activators. And the activators work in concert. They don't necessarily just work one individually separately, and together they actually, in some cases, can produce virtually synergistic phenomena. So I think we're still left with arterial thrombosis or any intervention that alters a vessel wall, that early on the platelets play a role, and then obviously the role of the coagulation system in supporting and reinforcing, and then eventually you'll find that there'll be relatively little effect of antiplatelet agents. So I think that creates the framework, and now the question is how to optimize the increasing number of tools that we have.
Great. So that's actually what we're going to try to work through with an eye towards the way clinicians try to grapple with integrating all of the issues that you just alluded to. So once upon a time, the original study, one of the original studies was done here, was the ATAC study, which compared aspirin, heparin, plus Coumadin, or the combination of all three, in a small study of looking at patients with acute coronary syndrome. And obviously, as we know, if we fast forward 2 decades to the contemporary approach, I want to sort of dive right into where we are today. So the platform from which we embark upon is one that's well known to all of us. The tactics trial, which again, I think we were a site for with John Ambrose. The trial that established once and for all the value of the invasive approach. The solid line on the top is patients who are quote-unquote managed conservatively, and the winning arm is the dotted line under here, patients who went early to the cath lab with about a 22% reduction. And essentially, since that time, medicine in the United States and in large parts of the Western world has been practiced the way we know it, where a patient is quickly stabilized on medical therapy and then brought to the cath lab. The truth is, though, if you look at the trial and you look a little bit more carefully at the curves, I think we begin to see, from a clinician's point, one of the sort of enduring dilemmas that we encounter. So in this slide, I've censored away the loser arm, the conservative arm, and we're going to focus exclusively on the winning arm. So this is the primary endpoint of the trial: death, MI, and rehospitalization for an acute coronary syndrome at 1 month at 6. Here's the same curve that we just showed before. And I just want to walk with you through the accrual of the endpoints, because I think there is an important sort of message that has continued to accumulate through subsequent clinical trials. Most of the trials have all, in the modern world, report endpoints at 30 days, 6 months, and then, depending upon how they go, further out in the acute coronary syndrome. I'm sorry that the red line is not projecting so clearly, but we're over here at the 1 month point, where the event rate at the end of 30 days was 7.5%. Okay, and then if you fast forward during the next 5 months, during the period when the patient is presumably out of the woods, you find what is the first exposure of really the Achilles heel of the way we do things. Namely, that the event rate in the second 5 months, when the patient is home, getting back into their life, getting back into their world, when we as the clinician, the cardiologist, have heaved a sigh of relief, more of the events happen in the second phase, in the latter part of the trial, than they do in the first phase. And the truth is, as you think about it, and we'll just run through a quick couple of set of slides, if you look at the shape of this curve over the ensuing really decades since the Tactics TIMI 18 trial came out, the shape of the curves is essentially the same. This is CURE, looking at the introduction of clopidogrel on top of aspirin for patients. This is the PCI CURE study, where again you see the same thing, a steep accrual of events in the first few weeks, but then a continuous, essentially relentless accumulation of events, such that more than half of the events in any clinical trial. Even if we look at the newest agents that are out there, here's the data with prasugrel compared to clopidogrel, here's the data with ticagrelor. The shape of the curves is the same. The absolute numbers has changed. So I think one of the things from a clinical point of view is how can we begin to grapple with this. And here's our first audience response question. So as we think about that late accrual of events, I'd ask for you to sort of input your opinion. The optimal approach to reducing these late events after an acute coronary syndrome managed with a PCI would be A, a better stent, B, a better antithrombotic agent, there is no right answer here, or C, better control of atherosclerosis risk factors. We'll just take a minute to accumulate we'll close in about another 15 seconds if everybody We seem to have a good response here. Just wait for a second. Great. Okay. So, so it appears that Dr. Sharma doesn't have a clicker. That's what we can learn from this. Okay, so Dr. Fuster, do you think we're right? Do you think our group is correct? 3/4 of the group think that we really should suspend our controversies right now because the answer lies not with a better stent, not with a better antithrombotic, but the fact that the long-term accrual of risk is attributable to better control of atherosclerotic risk factors.
I think it's exaggerated, but I think the priority system I am in agreement with, and there is data suggesting that control of risk factors make that curve, second part of the curve, much more flat. So, but I'm not entirely sure that the difference that shows in the slide by the answer really goes to that extreme.
Okay. Dr. Halpern, comment?
No, I just comment that I think this probably reflects reality, but it doesn't reflect what we do.
It reflects our opinions. Okay, good. So what I really wanted to do for the remainder of the time that we have together, about the next half hour or so, is use this sort of prototypical case. It's deliberately vague because I don't want to sort of get into the details of some of the stuff that's kind of peripheral to our conversation today. And as you'll see, we'll come back to this case over and over again as we try to sort of change some of the elements that might reflect different strategies that we use to manage. 72-year-old male, hypertension on therapy, previous smoker, no history of diabetes or confirmed hyperlipidemia, presents essentially with what we call unstable angina, crescendoangina, a couple of episodes of pain at rest. The last episode lasted 30 minutes. That's what prompted the EMS call, and that's what prompted the patient's hospital arrival. On presentation, so it's a very straightforward case. The pain is relieved with nitroglycerin. The patient has taken an aspirin along the way. The EKG shows anterior ST segment depression. The patient's troponin is elevated. They go to the cath lab. There's an 80% proximal LAD, and they undergo DES. Essentially recapitulating in the modern world the strategy that was outlined in the tactics to Maitri. We're all okay with that? So it's a relatively generic, on purpose, relatively straightforward case. Okay? So if we look at the guidelines, though, the guidelines are somewhat more obscure because they reflect the fact that there's lots of different options in terms of the management of the patients, in terms of selection of an agent, in terms of the duration. So let's assume for the moment that this patient receives dual antiplatelet therapy, and we'll come back to what that specific option is. As you see, all three of the options that are available to us, at least here in the European guidelines, ticagrelor, or prasugrel, or clopidogrel, all have a class 1 recommendation. So one of the questions that we clinicians often sort of try to understand, perhaps Dr. Sharma, you could help us here, is just run through quickly the algorithm in the cath lab by which you guys choose which one of these agents an individual patient like this would be getting. In other words, excluding the patient with left main, excluding the patient with a STEMI, just the run-of-the-mill unstable angina patient. Because from the clinical cardiology point of view, we typically defer to you guys in terms of the initial selection and starting of the antiplatelet agent.
I mean, one of the most important point which we always need to remember, that all these agents still have been tried, the newer agents of ticagrelor and prasugrel, only in acute coronary syndrome, ACS, non-STEMI, STEMI. Although we extrapolate in the stable patients, but only data are in those three groups of patients. And while it is shown to be effective, better than clopidogrel, but also you have to pay the price for bleeding. So that's where the judgment comes in. So if a routine run-of-the-mill case, which is not a very hard now to having a STEMI or non-STEMI, we usually go with the regular clopidogrel. Patients having, like today, we had 2 patients came to the emergency room having non-STEMI, and so those patients both actually received ticagrelor. So it just goes down to a younger patient. They're not old, no extra risk of bleeding. So that basically decides which therapy you go. And that actually is the data from the ACC and CPR at present also, that almost 70% of intervention in the United States at present are being done with clopidogrel. 30% are divided kind of the little more on the prasugrel and little less on the ticagrelor.
So I think certainly as a generalist, non-interventional cardiologist, that certainly reflects our observations. But I think to sort of summarize that, it appears to us is that the selection of the antithrombotic therapy is basically situationally determined. In other words, based upon, as you referred to a moment ago, the patient's clinical situation. So Dr. Hulot, the question is, can we do a little bit better going forward? In other words, is there a way to somehow incorporate the individual characteristics of the patient? And we'll start with this one, since this is one of the most widely reported and discussed issues, the genetic analysis. I believe you were chair of a writing group that basically left recommendations for us. So if you could sort of summarize in your mind what I, as a general cardiologist, perhaps should be speaking with Dr. Sharma at the time when the antiplatelet therapy is initiated, or before the patient goes home, or perhaps in the first week when the patient comes back to see me in my office.
Thank you for the question. I mean, it's true that, as you said, clopidogrel remains the one and the most prescribed prescription after PCI. So basically what is shown here is that the clopidogrel activation, clopidogrel is not active on the platelet pair itself. It needs bioactivation by your liver, and your capacity to activate clopidogrels varies between people, and some of the people basically don't have the right enzyme at the right place to activate clopidogrel. It's around 2 to 3% of the people who are lacking the key enzyme, which is called CYP2C19. It should be tested somewhere, and this is in the labeling of clopidogrel. It's not currently in practice, mainly for practical reasons, mainly also probably for reimbursement reasons, and because cardiologists don't have access and easy access to this information. But these 2 to 3% of people basically will never activate clopidogrel, and you have a bunch of data showing that they will never benefit of clopidogrel prescription. So this is the first point. Whether other people, carriers of one allele, and I'm talking about the remaining 20%, will not benefit from clopidogrel, this is another question. This is trickier, a tricky question. The thing is that we don't have any prospective data and clinical evidence that doing so, genotyping, adapting according to the genotype, will actually change the clinical outcomes on the long term. We don't know. We only have retrospective visions, pharmacological data, very strong, but no clinical evidence prospectively. So this is where we stand, and the big issue is, do we need this data? Because if we want to do so, it will mean that we need to have dedicated clinical trials with an enormous sample size, a lot of patients to identify these 2 to 3% of people where we know that they will never benefit of this. So the last thing is, genetics is good, okay, but it's only explaining a very small proportion of the non-response, or let's say a low response, and you need to have this integrated in an algorithm, as you asked Dr. Sharma, and a kind of face-to-face comparison with other factors, age, diabetes, smoking habits, and so on. And this is also what is lacking, is that we don't exactly know the weight and to give to the genetics factors, and how to now have a nice predicting algorithm and predicting score integrating these genetics data. This is where we stand right now.
So, Dr. Sharma, last year we did 5,000 something interventions here. What percentage of the time do we routinely check for platelet function?
Yeah, I mean, one which is very simple device, Acumetrics, is in the lab and gives you the readout of an absolute number, which is the PRU, platelet reactive unit. And there have been various cutoffs, either 208 or 230. That number above that means your clopidogrel not working, and lower means it's effective. And then you have a chance to switch. The question was, because of last year, maybe a handful of cases, maybe 100 cases we did. Usually those patients who come back with stent thrombosis or so, and we knew the patient was taking clopidogrel. Now, before that, we used to do quite, I would say, 3 years ago, probably we did 2,000 of the 5,000 cases. But then 3-4 studies showed that it really did not help in outcomes, the integration of platelet reactivity into a PCI model, whether you double the dose or change it to a more stronger agent, did not change the outcome. So it kind of has gone to the wayside, only used in selected cases and maybe very high-risk cases.
Dr. Kohler, should we be doing this more?
Earlier I had a chance to show all my disclosures, so I don't have a slide today, this afternoon, but it's important that I indicate that I have royalty interests both in apixaban and in the Acumetrics Verify Now assays. Verify Now assays, the technology for that actually came from research done in my lab while I was here at Mount Sinai. So Mount Sinai actually is the recipient of the royalty. Now, I think that a number of things have been said, and I think that they're all accurate, but I think that I have a slightly different sense of this subject. There have been a number of studies done looking at the genetics and looking at an indication of platelet function. And even in the people who are homozygous 2-2, some of them actually have not a terrible response to clopidogrel. Of course, on a percentage basis, there are many fewer. And similarly, there are people who have a very good response to clopidogrel. And so the question of how best to handle this complex situation where the genetics do not appear to be deterministic. In fact, if you go back to the genome-wide association study that was done, in the population that was studied, which was an interesting population, the Amish population, they found that the CYP2C19 variant could account for 12% of the variability in response to clopidogrel. And we had an earlier discussion of other genetic factors that are contributing. So I think that the CYP2C19 is a profoundly important discovery, and you're looking at a slide that attests to that. But I think we have to understand that this is not deterministic, and that's really the most important point that I would make. Of course, there's no question that Gravitas and Arctic were negative studies, and in fact, I just saw the follow-up to Arctic, which continues to be negative in terms of the impact of trying to modify dosing based on the testing. So there's no question that we do not have a pathway that is now validated for using this information on an individual basis. So I'm the first to say that, but we should not lose sight of the fact that there is overwhelming evidence showing association after association after association between outcome and the response to one or more of these assays. And again, I'm not pushing the Verify Now assay. There have been studies that have been done with a VASP assay and studies done with platelet aggregation response to ADP. So this is sort of assay agnostic. So we have that compelling body of literature that I think no one would disagree with. And we have this other body of evidence that shows that we haven't figured out how to convert that first body of information into something that actually helps the patient. So that's where things stand. In fact, there are a number of relatively small studies of where the clopidogrel or switching drugs has been used to guide therapy in relatively high-risk populations before PCI, and a number of them, in fact, show a clinical benefit in that very, very tight time frame. We have many other features that need to be appreciated. Earlier this morning, I spent a lot of time on the fact in the setting of STEMI that there's poor absorption of the oral agents. And so looking not at the first response, but looking at a month later may be a much more important way of approaching this. So there are dynamics, there are things related to the acute event and the impact on absorption and so on and so forth. There are a lot of complex things here. So I think that we need to keep an open mind about whether or not, in fact, in my own view, again, we live in a Bayesian world. we know a lot of things about the risk of stent thrombosis based upon procedural issues. We know a lot about the risk of stent thrombosis based upon whether or not the patient's diabetic and other clinical factors. We know information about the genetics, and we know that there's information related to people's response as measured by one of these assays. To me, the logical thing to do is to get back to the handheld device and to integrate this information for deciding which groups in which to think more seriously about this. And I would, of course, put in there the risk of bleeding as well, because that's going to be the trade-off if we do switch. So, as I say, I just feel compelled to go back and just emphasize that I don't think this is a dead issue. I think it's a dead issue that you don't have an algorithm today, but I don't think it's a dead issue that, in fact, we can't do better by eventually figuring out what would be the best trade-off in using this information.
Okay. Let's go back to the case and change one other element of the case. So it's exactly the same presentation that we had a moment ago. The only thing that's different here is the risk factor. The patient has type 2 diabetes and has been on oral therapy, let's say, for 7 or 8 years. So this is data from Dr. Badamone. So Dr. Badamone, as a clinician, should I think differently about how I initiate antiplatelet therapy if the patient is a diabetic? They've already had the ACS, so we're familiar with the fact that they're enhanced risk. Is there differences in the thrombus that I should know about?
I guess that what you should first, I want to say that to clarify, I'm a PhD, I am not an MD. So, but after saying that, I think that I still can give my opinion. So what we already know, as Dr. Kohler said before, one of the factors associated with on-treatment high platelet activity is the fact that you are diabetic. The problem is whether the diabetic does not respond to platelets, or maybe diabetes makes the platelets more active, and the treatment that you give is not enough to go back to the borderline of 240 PRUs that we use as verified now. But what we already know, and you as a clinician should be aware that diabetic is not going to have more problems because of the risk factor, but specifically in thrombosis, the platelets are going to be prime, they're going to be more reactive, and the thrombus probably is going to react less to the standard treatment that we use for everybody.
Dr. Bansalel, as a clinician?
Yes, I think I just view diabetics obviously in a different category altogether in terms of risk factors, and I think this is one population where we've shown with many mechanistic studies that clopidogrel may not be enough. There have been sub-studies from Trident where it's been shown that the risk, and Ben alluded to this in his introductory talk, that the benefit with prasugrel in fact is preserved, in fact heightened in the diabetic subgroup, and the risks are not as high. Dr. Badamone has studies sort of comparing now ticagrelor and prasugrel. There are other groups in Florida, in Marseille who've done this, where they've shown that ticagrelor in fact may provide even better platelet inhibition than prasugrel. So I would say my personal choice, I think to hone down from where Dr. Sharma started, is that especially in the diabetic population, I would in fact say that unless there are factors which worry me about the bleeding, I would consider maybe going with ticagrelor or prasugrel over clopidogrel. That's my personal opinion.
Dr. Fuster?
Yeah, I agree. I think the concept of risk here is critical when you compare clopidogrel with the other two medications. And I think regardless of the testing available, I think if you have an acute syndrome, complex disease, or diabetes, I believe that ticagrelor or prasugrel is the way to go. And if it is not yet, it's going to be soon. I mean, this is moving in that direction.
Perfect. Okay. So we'll go back to the original formulation of the case. The patient is a 72-year-old gentleman who came in with an acute coronary syndrome, ruled in for an MI with troponin, got the stent, goes home on some combination of dual antiplatelet therapy, and is now coming back to see one of us in clinic a week or 10 days later. Dr. Kohler alluded a moment ago to the approval of Vorapaxar just a week ago. Would we use, well, are they all turned on? Oh, great. Okay. So, Vorapaxar. Thanks, Steve.
Glad to meet that.
Okay, we'll wait another.
Is it diabetic?
So, Dr. Badamon, would you like to explain what this receptor is?
Yeah, well, I mean, it has been already alluded. So basically, the difference between Vorapaxar and the typical antithrombinic drugs is that the antithrombinics, what they do, they block the molecule of thrombin, and therefore you suppress all the mechanisms mediated by thrombin. In that case, what you do, you only suppress the effect of thrombin on platelets. Theoretically, it should be safer because you allow the thrombin to does not interfere with the cleavage of fibrin. The problem is that in the clinical trial,
Dr. Kohler, does that sound what we should know about it?
Yeah. Well, first, it's a great scientific story. Sean Coughlin's group at the University of California in San Francisco really did a fantastic job in identifying this receptor many years ago, and there's an incredibly elegant basic science story behind this, because for many, many years people fought tooth and nail, and Valentin and Juan will remember these fights over, is thrombin working as an enzyme? Is it working as an agonist on a receptor? There were fascinating data both ways, and the way it got solved was that, in fact, thrombin actually cleaves a portion of the receptor, the N-terminal region, and exposes a new N-terminus, which then fits into the receptor and activates the receptor. So everybody was right and everybody was wrong, and it was just wonderful to finally see it, and now we even have a crystal structure of it. So I would say we are on about step one of about 1,000 steps in understanding exactly where PAR1 inhibition fits into the process. As you know, there were false starts with the initial study of this agent, and I think it's going to take a long time to figure out just where it goes, so I voted for number 3. And I think that it's great to have more drugs out there because it gives us more flexibility, but it also taxes us to think about the design of trials that will actually answer the most meaningful questions. And I think that people need to sit down now with this new drug and think about just where the sweet spot might be for it and which populations are likely to have the greatest benefit to risk ratio. But can I just make one other point, though, because we've sort of, knocked aspirin here. We haven't talked about aspirin, but in the diabetic, the issue of aspirin is profoundly perplexing to platelet people, because people would think diabetics, they have high risk, they've got active platelets, they should really have a great benefit from aspirin. But people like me and Valentin and Juan digging into the literature, you turn up this dry well of real frustration about why aspirin seems not to work so well in diabetics, as well as clopidogrel. And I think there's one interesting hypothesis that's worthy of testing, and that is studies, and again, Valentin did a lot of the platelet turnover studies, showing shortened platelet survival in diabetics. And this has raised the issue as to whether or not the problem with aspirin in diabetics has got to do with the frequency of dosing rather than the dose itself. Because, as you know, the acetyl group leaves very quickly. It's essentially a bolus therapy, even if the salicylate sticks around for a long time. And so the issue of whether or not diabetics should be treated twice a day with aspirin or something like that, I think is something that we need to think about. I don't have to share with this group the importance of understanding diabetes better and treating diabetes better given what's going on. But I think that we should really not give up, even though aspirin is off patent, and therefore doesn't have maybe some of the pharmaceutical muscle in terms of the interest in doing additional trials. I think we should keep it in mind that maybe we haven't optimized the value of that drug in this disease.
Just a comment. I think the dose of aspirin is not settled, which is something quite amazing that today in 2014, we ask the same question. But I personally think that the reason why aspirin is not working in diabetics and not in peripheral vascular disease is because the burden is so high that the dose of 80 milligrams is really not reaching the threshold of inhibition. And I think we'll have to change the dose. And it's just, maybe it's a prediction, but certainly I think it's in that line.
Sorry, can we continue? Can I ask a question to the panel? What do you think about the recent response of the FDA to the Bayer's citizens petition for aspirin in primary prevention? And my question to the panel is, what does it mean, primary prevention? Should we talk about high and low risk rather than primary prevention and secondary prevention, or vice versa? Will you give aspirin to a diabetic even though it's primary prevention?
John?
Well, you're asking the right question. We have patients without events who have a high burden of disease, whether they be diabetic or non-diabetic, and we have patients who are at risk of developing a disease but have no evident atherosclerosis, and we need to subdivide these populations to understand these roles. We know that in relatively low-risk patients, aspirin can have paradoxical effects, and so I think it's important to distinguish the primary prevention role of aspirin based not only on whether or not there's been a clinical event, but based in part on the burden of disease.
So I, like you, were fascinated by what the FDA did, so I read their letter as carefully as I could and then reread it several times. They make quite an amazing statement saying that even though they can't find the evidence to support primary prevention, they realize that clinically people might conclude that individuals at high risk are more like people in secondary prevention and therefore might consider the therapy even if the FDA at this point has not found the evidence to support it. However, they also pointed out that if you actually look at the risk stratifications that have been done in primary prevention, they do not follow the expected high risk getting the greater benefit. So they do point that out. But frankly, if I were at Bayer, I don't know why they did what they did. What I would have done would have come in for the colorectal carcinoma prophylaxis as the reason for primary prophylaxis with aspirin. And I think that we're going to see much, much more interest as the dissemination of the knowledge about the impact of aspirin therapy on colorectal in particular, but other forms of cancer, that in addition to the British epidemiologic studies in 2011, 2012, I just saw essentially a confirmation from the Women's Health Initiative. This is not going away, and I think that that background is in some ways really quite compelling. Platelet people get very excited about these data, by the way, because a number of those studies were done with doses of aspirin that are, at least by standard criteria, unlikely to be inhibiting COX-2. And the people who've worked on cancer, especially colorectal carcinoma, and aspirin have focused a lot on COX-2. But the doses that in these studies that show benefit are often relatively low doses. And in particular, Garrett Fitzgerald years ago wanted a formulation of aspirin that would inhibit platelet cyclooxygenase but not endothelial cell cyclooxygenase. So he came up with a formulation that would only affect the pre-systemic circulation, which meant that theoretically by first pass in the liver, none of the acetyl group would ever get out into the general circulation where it could get to endothelial cells or get to a tumor, for that matter. So I think that there's a lot of speculation that, in fact, this primary prophylactic benefit of aspirin in this setting may, in fact, be operating through its effect on platelets. And in particular, there's a lot of focus on the reduction in metastasis formation. So I just put this out as general background because I think you're going to wind up with the population more and more on aspirin as a default based on these data rather than necessarily the cardiovascular benefit.
Great. So now we've got to move a little bit because there's a lot of good stuff that we still want to talk about in the next 20 minutes or so. So although our group, as we saw, is instinctively conservative, small c, in terms of new data, the drug is already out there. So Dr. Halpern, these were the two trials that basically looked at the role of Vorapaxar in patients such as this. Should we be using this drug? Or how should we be using this drug?
I think the conservative is reasonable. I was a little surprised that it was approved, but the mortality benefit was, of course, not seen as an isolated endpoint, but in TIMI 50, they showed a reduction in the composite endpoint of reinfarction, if you will, because these are 70% post-MI patients, or MACE in terms of mortality. And I think the reality is that the drug does have a benefit in reducing events. It looks, the design of the trial was very similar to the Capri trial that led to the approval of clopidogrel compared to aspirin. Here we have a drug, the PAR1 receptor antagonist for Vorapaxar, that showed a similar response to patients who were treated with a pre-existing platelet inhibitor, generally aspirin, but the results were true for those receiving clopidogrel. Here, patients entered post-MI or with peripheral arterial disease. The arm of the study that were the post-stroke patients were stopped. The drug did not work particularly well in an ACS population, but worked in a chronic disease population. It was a little, I will say, unsettling in the sense that the greatest benefit accrued to those patients who entered post-MI, and there was a distinction there between the way Vorapaxar responded than the way clopidogrel responded in the earlier Capri trial. There was, as we understand, an increased risk of bleeding. That risk was relatively modest, and I think the overall net benefit of the drug was favorable, leading to its approval. I think we still have to find which patients are the ones most likely to benefit. So we have a new element in our armamentarium, but I'm not quite sure that we know yet how to use it.
Okay. So back to our straightforward patient. The patient undergoes a drug-eluting stent to the proximal LAD, and he's discharged with prescriptions for dual antiplatelet therapy, whatever that might be, statin and a beta blocker. So the question for today is, for a patient getting a contemporary generation drug-eluting stent, the appropriate duration for dual antiplatelet therapy for this patient is, if everybody could just... So while we're waiting for this to come in, because I think people have a lot of opinions, Dr. Fuster, should we be using Vorapaxar? Yes, no? A lot, a little?
Not yet. The statistics are not conducive.
I was actually surprised the drug was approved. With the fatal intracranial bleeding, and so some part of the study was stopped because of that.
Yeah, it's one of the...
So I have to speak up because I have the
Lucky
privilege
you weren't on the panel.
So I think, having worked with the TIMI group through when the stroke arm was stopped, and I think their biggest justification obviously is that the prior MI group in itself is larger than most MI trials that are conducted in this day and age. And I think if you sift through the FDA documents, you'll see how they go through that convincing argument. And I think just to make the point is that if you're going to look at any drug data, I would say the FDA documents are a better place than the New England Journal to study any drug. So I think when you look at what happened with Vorapaxar, that they clearly, and it's similar to the labeling that the FDA has gone, we have to realize that the FDA doesn't go by the New England Journal publication, just as the prasugrel label has, carved out a certain Capri-like cohort, taken out people with certain low body weights, advanced age, and prior stroke. It's the same concept that there is a certain benefit-risk ratio that the FDA looks at, and their main focus is to get a therapy which is safe or relatively safe and has a certain benefit associated with it to the population. So I think that's where their focus comes from.
Okay. So back to here, the optimal duration. 2/3 of our group thinks that the appropriate duration for dual antiplatelet therapy for this patient is up to 12 months, and the other 40% are sort of divided. So Dr. Sharma, here was the optimized study. comment on that for
I
a
mean,
second?
those actually the trials have done to look into it, that can you reduce the duration, first 24 months, then 12 months, and then maybe 3 months. And it seems to be that in some cases, and particularly the type of stent, all the stents which were done, which are used the least in the United States, and that is the Medtronic Endeavor stent. Those were the part of the reset as well as optimized. But yes, the duration is decreasing, and while we still have a 12 months, maybe the newer focus update may decrease the duration, it still remain 12 months. But in Europe, it has gone down to 6 months, and after 6 months, chance of stent thrombosis are extremely low.
Dr. Fuster?
It's even in Europe is using 3 months. Many institutions are still doing that.
But we should still adhere to 12 months. Is that what you're doing in your practice?
You're in charge.
I work for you.
Send the guideline to the anesthetic.
We'll come back to that in a second. We're coming to what happens if it has to be interrupted. But assuming that everything is sailing along, the patient's having no problems, no untoward events, no hemorrhage, no minor bleeding, full 12 months still for a patient getting a stent May 19th?
Well, I mean, right now you have to, because there is no other guidelines in U.S.
Perfect. That's perfect. Okay. And Dr. Sarma, a word about the bioabsorbable stents, one word?
Yeah, this is another very exciting, the device which absorbs takes about 24 months. The whole concept is that you won't need a long-term antiplatelet therapy, but the trial which was done, Absorb 3, which compared with their metal drug-coated stent, Zions, versus the bioabsorbable, it still gave antiplatelet therapy in both the arms. So we would not know whether you could reduce it, because both the groups received for 1 year. Yeah, it's while we are still doing the trials here, this stent is available out of US, in Europe, India, and other places, and it's particularly in the younger patient population, easy access, not a difficult lesion, not a bifurcation lesion, is being used with a great safety as well as lower, because the randomized head-to-head trial has not come out yet, but seems to be lower restenosis also.
Okay, good. So we're leaving the patient on for 12 months, except for the following kinds of circumstance. This is from a gentleman I saw last week. The patient has a remote history of prostate cancer 7 or 10 years ago, had a TURP then and radiation therapy, which was extensive, presumed to be cured, doing fine. 10 weeks following PCI for an LAD, acute coronary syndrome, he develops hematuria. Long story short, GU evaluation reveals a new primary bladder cancer, which they actually think was attributable to the radiation that he received the first time around, and he requires an open radical cystectomy 10 weeks following an LAD stent on dual antiplatelet therapy. So, in terms of preoperative evaluation and recommendations for antiplatelet therapy, we have a bunch of different choices here. It's a little bit more complicated because these reflect, there's no right answer here. As Dr. Fuster knows very well, all of these have been on display at Mount Sinai in the PACU in the last 6 months. So again, the patient's going to have surgery a week from today. He's on dual antiplatelet therapy right now for an LAD stent that took place 10 weeks ago. We have the options for stopping both aspirin and clopidogrel for 7 days, stopping the clopidogrel and continuing the aspirin, stopping the aspirin but continuing the clopidogrel, and then the fourth option, which is to stop both agents and at some point during the next 7 days to bridge the patient with some adjunctive agent, either subcutaneous low molecular weight heparin or admit the patient for an intravenous glycoprotein 2B3A antagonist. Okay, everybody have their choices in. We'll wait another second. So, Dr. Halpern, why don't you start here? Let's see what the...
Very hard situation, obviously, whatever you do is the wrong thing.
That's why I gave you first.
Whatever, but I think I chose choice B. I would continue the aspirin. I would stop the clopidogrel. That probably will reduce to some manageable extent the risk of bleeding, but still provide some antiplatelet efficacy. This is the one place where I think there's a solid role for aspirin.
Okay, it's interesting, Dr. Sharma, that a third of the people in our group would bridge the patients with low molecular weight heparin or IV 2B3A.
You said there's no data it does anything.
The question would be that stopping both the drugs, very selected situation, particularly neurologic, patient going for neurosurgical or any neurologic procedure, and that is where the recommendations were. And it's a very high risk for stent thrombosis. We did a Science V USA with the Science stent that after 1 month, in a routine case, in 500 plus cases, stopping clopidogrel after 1 month, there was no thrombosis. In a more complex cases, after 6 months was 0. So routine case, you could, if it's a straightforward proximal LED, not a bifurcation, but not an MI situation, you could even after 30 days, you don't need to do something. We used to do a lot of bridge, particularly with old stents, and give low molecular heparin. We are now given 2B3A here at Sinai. But stopping both will be the actual teaching always has been that continue one antiplatelet therapy, and we every day we get a call from various surgeons, dentists, and so they want to stop both, but you have to force that you continue one antiplatelet therapy.
So, Dr. Fuster, which one do you continue? Assuming the surgeon says, I'll let you have one.
Yeah.
Okay.
We are close to 3 months, which is what we discussed before.
10 weeks, smack in the middle.
So the chances of a clot obviously is very, very small in this particular case.
Okay, good. We're going to keep moving? Okay, Dr. Fuster, we keep going? Great. So we have the data from the Paris study. Dr. Sharma, in a word, just what did we as clinicians learn from Paris, which was actually done by Roxana?
Yes. The Paris, basically, the study was to see the pattern of discontinuation, interruption of antiplatelet therapy after stents, particularly drug-eluting stent. And basically, they found is that if the discontinuation or interruption was done under physician guidance, it did not lead to a higher event rate. But it was done by patient stopped it, or patient has some bleeding for some reason without under guidance, that was led to higher cardiac event rate. So basically same, because just like the previous slide, what you will do, patient has GI bleed, patient needs surgery, patient needs cystoscopy, you'll continue one therapy. Other patients who may decide to stop just for 1 week, same way, but stop 1 drug or 2 drugs and not getting into the event to restart, and so all this leads to higher event rate. So that key physician guided and versus the patient guided. I think that basically the message was that brief interruption is not associated with higher stent thrombosis.
I mean, I think one of the main lessons from DAPT, at least as we as a division sort of struggled with anesthesia to come up with a guideline, was 2 things. The fact that the overwhelming majority of the things that we're afraid of, which is events like stent thrombosis, 3/4 of the events or more happened while the patients were on antithrombotic therapy. The other thing is, while we worry about exactly what to say in the pre-op clearance note, by the end of the first year, 1/4 of the patients have discontinued at some point their antiplatelet therapy, and by the end of 2 years, which obviously was taking place at a time when perhaps they should not be on dual antiplatelet therapy, more than half of the patients, one way or the other, had stopped their own. We're just going to keep going to move forward here a little bit. This was what I was going to ask, but Dr. Badamone jumped the gun. Now to sort of 2 more interesting permutations. So same case that we talked about before, 72-year-old male, hypertension, presents with an acute coronary syndrome. The only difference with this fellow is that the patient has long-standing atrial fibrillation. Quickly looking, he's a CHA2DS2-VASc 3 or more, chronically on an INR of between 2 to 3. So for this patient already receiving long-term anticoagulation, who's undergoing a PCI involving a drug-eluting stent for ACS today, the patient, remember, is on long-term anticoagulation therapy. Should we go back to reconsider that original recommendation for 12 months of dual antiplatelet therapy? And if so, how? We have some choices here, if everybody could vote. So Ben, you alluded to one of the data points that surrounds this.
I was actually hoping you didn't see me, but so
it pays you quarter.
So to make this decision, I think you certainly have to look at the data. The 2 trials that were most prominent were the Lambert trial, and this was a retrospective study where they looked at a number of patients with atrial fibrillation. I think it was close to over 10,000, and who had either MI or PCI, and then followed them for for the outcome of the different combinations of antiplatelet agents, and it showed that clopidogrel and oral anticoagulant had less bleeding but equal efficacy. The other trial...
So this is the slide from your handout, which exactly shows that an oral anticoagulant plus clopidogrel in the orange dots at the bottom was superior in terms of efficacy to either an oral anticoagulant plus aspirin or aspirin plus clopidogrel. Obviously, the trends in bleeding reflected that, and all-cause mortality as well.
The other trial that's probably the most well-known is the West trial, where they took patients with atrial fibrillation who underwent PCI and then randomized them, I believe, within a week of PCI to either receive aspirin, to either receive clopidogrel or dual antiplatelet therapy. And it showed that the patients that received the clopidogrel and not DAPT actually had, as you would expect, less bleeding, but also the rate of stent thrombosis was the same as the other groups. I think there's two kind of caveats to point out with those situations. One is that, as Dr. Collar was mentioning earlier, you have to consider the individual risk and comorbidities. I don't know if subgroup analysis in these patients would show that certain patients with diabetes or chronic kidney disease may or may not have variable responses. And the other caveat, which I think is probably one of the most important caveats, is that these studies were done on patients on warfarin and not on the novel oral anticoagulants. So as we start to use the novel oral anticoagulants much more, we don't really have answers comparing them to clopidogrel, and certainly not to the new thienopyridines.
Can I just make we use these terms anticoagulant and antiplatelet as if they're a Manichaean dualism, if you will, but they're not. All anticoagulants are antiplatelet agents because, as we've already said, thrombin is one of, if not the most potent platelet aggregating and platelet activating agent that we have. So by definition, an anticoagulant will be adding an antiplatelet component, and I think that's an important point to keep front and center here.
Okay, so basically the consensus of our group, as Ben was alluding to from the West, that the use of dual combination of clopidogrel plus an older oral anticoagulant seem to be associated with the least bleeding. That's, John, that would be your recommendation?
Right. Again, we use a lot of references to the Worcester trial. Keep in mind, it's fewer than 600 patients. The primary outcome was based on an open-label assessment of the primary outcome, which included relatively minor bleeding, and that I think we need to recognize that this is kind of hypothesis generating, and it may as much be an anti-aspirin study as a study favoring the use of clopidogrel plus warfarin. So there are a lot of unanswered questions at the end of Worcester.
Right, and along those lines is a paper that was just in Circ a few weeks ago, which seemed to reach the opposite conclusion in a more stable group. But to sort of go to the last question, so again, back to our standard case, and we're going to do this one fairly quickly, so get your clickers ready. Same situation that we've talked about. The patient has undergone a stent, again, a few weeks ago for the LAD on dual antiplatelet therapy, and at this point comes for some other clinical appointment and is noted to be in atrial fibrillation of unknown duration. Putting aside, in the interest of time, how one would prefer to approach new onset atrial fibrillation, because we'll be here till the next controversies with these guys on the panel in terms of that. The question is, what should we be doing in terms of antithrombotic therapy? So the patient at this moment is on aspirin and a second antiplatelet agent, and again is going to be on anticoagulation for some period of time for the atrial fibrillation. Dr. Fuster, you want to start with this one?
I don't know where. They use coumadin and clopidogrel. That's it.
Okay.
I don't know which A, B, C, D, H. I cannot read it.
Okay.
I think it's E.
Yeah, so that was one of the choices here. Whoops. Yeah. Okay, so the preponderance of it was add either a novel or oral anticoagulant or a vitamin K antagonist or warfarin to clopidogrel while stopping the aspirin. John?
Well,
So this is the data
keep
from
in
RELY.
mind that patients on dual antiplatelet therapy following percutaneous coronary intervention were excluded from all of the novel oral anticoagulant trials. So we have absolutely no current evidence base upon which to use that. And I think, we have very little evidence for the value of aspirin in patients who have undergone PCI with deployment of a stent. We have very powerful evidence in favor of a thienopyridine or P2Y12 inhibitor, and I think we should therefore rely upon the thienopyridine in this case, add the anticoagulant that we have the best evidence for in the patients with coronary disease, and that's warfarin. Recognize the risk of bleeding is there, but this is a complex case, and stay away from fringe medicine in a situation like this.
And to answer further question, there are a few trials ongoing to exactly answer the newer agents, and we are one of the pioneering trials. There are a few others.
The new agents thus far as being used at a dose that is funny to me because it's not the dose being used for atrial fibrillation.
No, not at all.
So I'm very, very concerned of the outcome of the new agents in this situation because it's not the type of dose.
Well, one of the arms is close. One is a 3-arm study. One arm is 15 milligrams of rivaroxaban plus clopidogrel, no aspirin. One arm is a very low dose of warfarin used in the Atlas 2A study, the 2.5 milligram BID rivaroxaban plus dual antiplatelet therapy for the dual antiplatelet therapy period, followed by aspirin alone. And the third is the conventional warfarin plus dual antiplatelet therapy followed by warfarin plus aspirin alone. So one of them is close to the dose which is used in the 15 milligrams daily. Yeah. And that's the Pioneer PCI trial, AF PCI trial.
Okay.
With one single agent?
Sorry?
One single antiplatelet?
So there are 3 arms.
No.
They use only from day one. You get the stent and you put in 15 milligrams of rivaroxaban plus clopidogrel. It's a kind of Wust-like study, and then the other two, no aspirin in that arm at all. Exactly.
Okay. So
And by
it's
the way, the other trial that's running is with dabigatran, low dose or high dose dabigatran plus dual antiplatelet therapy, and then a tapering off period.
So we covered everything, and it's actually 6:30. So, Dr. Fuster, if there are any questions from the
I think
audience?
it's great. Thank you very much. I think it's wonderful. You touch into the right issues. I think it's a pleasure to see these kind of people here who have contributed so much into the field. I think it is very quite amazing. Thank you.
Thank you.